Good day, my name is Luis Gabriel Parra-Lara and I am fellow in hematology and clinical oncology at Universidad ICESI and Fundación Valle de Lili in Cali, Colombia. I will present to you the study entitled Survival for Colon Adenocarcinoma in a Hospital-Based Cancer Registry in Cali, Colombia. To set the background, it's essential to begin with population-level data. This table summarizes the long-term trends for colon cancer in Cali based on the Cali PBCR. Focusing on the most recent period, the age standardized incidence rate was 17.3 per 100,000 for males and 14.3 per 100,000 for females. Long-term trends show a steady increase since 1962, with a positive annual percentage change of 2.2% in males and 1.6% in females. Mortality rates for 2016 to 2020 stand at 10 per 100,000 in males and 8.1 per 100,000 in females, also showing a rising pattern. When analyzing 5 years net survival, we compare PBCR with SEER database from United States. In the earlier period, the survival difference between our region and the US was 16.4 percentage point. Then, this gap narrowed to 9.7 percentage points. Although this improvement is encouraging, a 9.7% gap remains a major clinical and public health challenge. This persistent disparity demonstrates that, despite progress at the population level, we still lack the clinical data necessary to identify prognostic factors and design targeted interventions. In Colombia, the PBCR has provided invaluable data for over 6 decades, showing a gradual increase in incidence and improved survival, associated with broader access to diagnosis and therapeutic services. However, HBCRs complement PBCR by offering more detailed clinical, pathological, and therapeutic data. That is why our research question was, what is the overall survival of patients with colon adenocarcinoma cared at Fundación Valle de Lili? We conducted a retrospective cohort study using data from the HBCR between 2015 and 2022. We included adult patients aged 18 years or older with histologically confirmed colon adenocarcinoma. We excluded in situ tumors, multiple primary malignancies, or cases with incomplete follow-up. Cases were classified as analytical or non-analytical. We analyzed demographic and clinical variables. Statistical analysis included Kaplan-Meier estimates for survival curves, log-rank tests for group comparisons, and multivariable Cox proportional hazard models to identify independent predictors of mortality. We also conducted exploratory analysis in patients younger than 50 years and according to biomarker testing. We analyzed 1,643 patients with colon adenocarcinoma, out of more than 35,000 cancer cases registered during the study period. The median age was 64 years and 55% were female. Most patients were treated under the private system, 90%, and about half were analytical cases, meaning they received the first cycle of treatment at our hospital. Regarding tumor location, 55% were left-sided, 39% were right-sided, and most cases located in the sigmoid colon. At diagnosis, the clinical stage was 26% had localized disease, 29% were locally advanced, and 20% presented with metastatic disease. Respect treatment, overall, 94% received initial treatment, while 2% received palliative care only. After a median follow-up of approximately 32 months, 564 deaths were recorded. Overall survival was 86% at 1 year, 73% at 3 years, and 65% at 5 years. When stratified by sex, survival was higher among female patients, 67% at 5 years. By age group, outcomes were best in the 35 to 69 years group, with 71% 5-year survival. There were no significant differences by health system affiliation. This could be explained because most cases were privately insured. Considering tumor location, right-sided tumors showed slightly better survival, although the difference was not statistically significant. By clinical stage, survival declined sharply from 84% in localized to 78% in locally advanced and 18% in metastatic disease. In multivariable analysis, male sex was associated with a 23% higher risk of death. Locally advanced and metastatic stage had 1.7-fold and 11-fold higher risk, respectively, compared with localized disease. Left-sided tumors were associated with better survival. This study provides updated and locally relevant evidence of colon adenocarcinoma survival in Colombia. In summary, colon adenocarcinoma remains a significant public health concern in Colombia. Sociodemographic and clinical factors play a critical role in survival outcomes. Health system fragmentation contributes to inequities in cancer care. Hospital-based registry are essential tools for surveillance and quality improvement. Future efforts should focus on strengthening cancer care networks, expanding molecular diagnosis, and ensuring equitable coverage across insurance regimens. Consolidating hospital-based registry networks will be crucial to improving survival and advancing cancer control in Latin America and the Caribbean. I would like to sincerely thank to all these people whose dedication made this research possible. This study is dedicated to all our patients who inspire us every day. Thank you very much for your attention.